Okay. Ma'am, we are live. Yeah. So, good evening, everyone. Welcome to Nephrocon's web series. Nephrocon is a platform integrating nephropathologists and nephrologists. One of the agendas of the forum is a monthly webinar series conducted on the first Friday of every month. The webinar consists of a talk by a nephropathologist in the first half, followed by a panel discussion with nephrologists. We have successfully conducted webinars since October 2023, with the technical support being provided by Akognos as our academic partner. We have a dedicated WhatsApp group and a YouTube channel where all the previous webinars are available, and you all can access it from there. The last webinar was about myeloma and kidneys. And today we shall be discussing renal amyloidosis. At the outset, I'd like to point out that tomorrow is International Women's Day. And behind every healthy kidney, there's a nepropathologist helping nephrologists one cell at a time. So I may not have the exact statistics, but I believe the maximum number of nephropathologists in the country are probably women. So to honor that and to celebrate that, we have Dr. Meenakshi ma'am. She's a nepropathologist at Apollo Hospital, Hyderabad. And she's our guest speaker today, highlighting about renal amyloidosis. So I wish you a very happy Women's Day, ma'am, and everybody in the group in advance. And I'd pass on to you for further discussion, ma'am.
Hello. Am I audible
Yes.
and visible?
Yeah. Yes.
Thank you, Dr. Purva, for that lovely introduction, and happy Women's Day to everybody. So let's start over the next 20 or maybe a little more than 25 minutes. I'll quickly, is the screen visible?
Yes, ma'am.
So I'll take you through renal amyloid and its differential diagnosis. So one second, yeah. So we'll begin with definitions, because I'm sure we have some young people in the crowd who may or may not be so familiar with this. Amyloid, the term actually dates back to the 1800s. And amyloid actually is derived from the term amyloin in Greek or amylum in Latin, all of which means starch. And so this name has now been imbibed into many fields, including biology, where it implicates a starch-like material. But definitionally, amyloidosis is a group of diseases which is characterized by deposition of abnormally folded proteins or misfolded proteins, which have a conformational change, essentially leading to a beta-pleated secondary structure. And I'm sure that many of you have heard this term. But what does beta-pleated mean? It essentially means that the polypeptides are arranged in a zigzag manner. So this conformational change confers great stability to this protein in physiologic conditions, so it doesn't get degraded easily or removed easily. And also in the process, it acquires a great affinity for congruent stain. And therefore, all amyloid actually are congophilic and often birefringent under polarized light. So these are definitional features of amyloid. Deposition of this abnormal protein in various tissues leads to the disease amyloidosis. And that is why we are discussing it today, because all amyloid always involves the kidney in addition to other organs. So etiopathogenetically, we know of 36 precursor proteins at least have been identified, which are amyloidogenic. And 14 of these appear to be associated with systemic amyloid. 19 are localized forms, and there are 3 which occur both as localized and systemic amyloidosis. How does this protein come about? It could result from any of these ways. Either there could be an increased production, as would happen in plasma cell dyscrasias. Plasma cells are the source of protein in the body. So any clonal expansion, a neoplasm of plasma cells or a proliferation of plasma cells could lead to excessive protein production, which if it is more of a light chain, leads to AL amyloid. If it's more of a heavy chain, then it leads to often monoclonal, so not more really. If there are light chains are synthesized, it results in AL amyloid. Heavy chains are synthesized, that results in AH or heavy chain amyloid, and there could be combinations of the two. Alternatively, there could be decreased excretion, and that is the pathogenesis underlying beta-2 microglobulin type of amyloidosis. In chronic inflammations, however, that is associated, which is associated with AA or serum amyloid protein, amyloid-associated protein. And in genetic conditions, there are mutations in multiple proteins leading to the production of abnormal proteins which get deposited in tissue. So interestingly, 90% of renal amyloid are either of these three types, either AL, which constitutes the majority and is a point of interest for all of us, followed by AA or ALECT. And the rest 10% is constituted by the various other forms that we are going to discuss shortly. More importantly, in adults with nephrotic syndrome, up to 5% can have amyloidosis. That's for a little bit of statistics. But looking at the classification, there are 5 different classes depending on the cell of origin. If it's neoplastic and it arises from a clonal plasma cell or B cell proliferation, you have AL and AH amyloid. When it's associated with chronic inflammation, the protein implicated is AA protein, serum amyloid A protein, which has a few cases of hereditary inflammatory syndromes as well, but large majority are not hereditary. Then you have the genetic amyloidosis, where you have all these various types, majority being apolipoproteins of various types, excepting type 4, which is not a hereditary one. If there's decreased excretion, can you hear? Am I audible?
Yes, ma'am.
Yes.
Yeah. So if there's decreased excretion, that results in the type of amyloidosis known as A beta-2 microglobulin. Everywhere you would notice that there's a prefix A, which stands for amyloid. And the protein is for the name after that is the protein concerned. So here it's amyloid beta-2 microglobulin. And ALEC2 is still, as of now, an unclassified type of amyloid. Its pathogenesis is not really very well understood even now. But most importantly, if you look at this third column here, all these types of amyloid, whatever type it may be, involves the kidney. And that is why we are discussing it in today's forum. So now looking at the various types of amyloid with kidney involvement or predominant kidney involvement, the first 3 types, AL, AH or AHL, AA amyloid and ATTR or the transthyretin type, involve all the 4 compartments of the kidney, the glomerulus, tubulointerstitium, and the vessels. In contrast, ALEC2 involves the tubular interstitium, which I've highlighted in this in the yellow color, followed by the vasculature and less commonly the glomerulus. Similarly, again, I've highlighted these 2, which is apolipoprotein type 4 and lysozyme, which have an affinity for the medullary tubular interstitium. So it's important, not necessary to remember, but important to know that they can selectively affect different compartments, depending on the type. Now to look quickly at the pathology. How does it look? Now, this is a case from an amyloid case that we had, where you can see these are the glomeruli, which are markedly enlarged. And this is the H&D stain, which, if you look at this glomerulus, there's a very marked expansion of the mesangium by this eosinophilic acellular material. So the cellularity is quite intact, but the mesangium is expanded by this pink substance. And characteristically, this material is PAS negative. So on the PAS10, which is an essential part of every kidney biopsy evaluation, the PAS would be negative or weakly PAS positive. This is an important point to remember. The mesangial matrix in these cases actually gets destroyed by metalloproteinases, which are activated, and the entire matrix gets replaced by amyloid fibrils. The other feature of amyloid is that these are non-argyrophilic. And these are important points which a pathologist use while making diagnosis, because a silver stain, again, is an essential component of renal kidney biopsy interpretation. And if you look at this picture on the right, the blue arrows point to the amyloid deposits, which are seen in the glomerulus on the left as well. And they are pale PAS positive or PAS negative and silver negative. You would notice that all the glomerular basement membranes are highlighted by silver stain, which is black in color, marked by the curved arrows, and the blue arrows mark out the amyloid deposits, which are not silver positive, they're silver negative, and hence non-argyrophilic. Congophilia, all of you would have heard, is a very important characteristic feature of amyloid. And if you look at the picture on the left, the entire deposit in the mesangium, there's a very high magnification just to show you this feature. is intensely red, but it could be just a plain, simple rose pink or salmon red as well. Apart from being congophilic, these deposits actually, if you look at the picture on the right, is a picture taken under the polarizer, shows what is known as apple green birefringence. And you would notice that not all of it is green. There's a lot of green, but there's also variably orange and yellow. And that's how it looks actually under the microscope. These are some more pictures taken from a more recent case. This is a glomerulus. You can see the green birefringence up there. There's another smaller glomerulus here. To the right, you have a blood vessel, which is also showing birefringence under the polarizer. So this is an essential feature. It is a little difficult to demonstrate, may not always be possible to demonstrate, and also to take a picture sometimes can be quite difficult. So how do we diagnose cases of amyloid? At various levels, at the light microscopy level or under the bright field, you see these eosinophilic deposits, which I just showed you, which are pass negative and congophilic, so they're Congo red positive. When you do the IF, you could have a light chain restriction, which means that one light chain is visible. Say, for instance, more commonly, the lambda is visible, but there is no staining for kappa. And this is equal to a light chain amyloid or AL. If, however, they're polyclonal, that means on IF, you had both lambda and kappa light chains, then it was not a monoclonal one, so it's unlikely to be AL. You could run an IHC stain for AA, which is readily available in most laboratories. Should that stain positive with AA IHC, it becomes an AA amyloid. Now, actually, ALEC2 also has an IHC available. We don't have it with us, but yes, that is available. And maybe in time to come, we will also have it. It'll be possible to do it in our laboratories. Of course, there are many other types which may not be these three common types, in which case confirmation is always by electron microscopy, which will show you random non-branching fibrils, which are usually 8 to 10 nanometers, maybe up to 12 nanometers in size. Now, proteomics is the in thing today. So I think we have to know it, especially with regard to amyloid. Proteomics is nothing but study of protein, and amyloid is deposition of protein. So essentially, we study the protein that is deposited, but how do we do it? This is done by a technique, very highly specialized technique known as laser microdissection, where the glomeruli are stained with Congo red. The Congo red positive glomeruli are scooped out by laser microdissection, so that material is extracted from there. And by several steps thereafter, it is subject to mass spectrometry, which detects these amyloid fibrils or proteins. And it's very sensitive and specific, and it can detect up to 97% of amyloid. So that's a great advantage of proteomics over the other tests. This is a table which I have actually taken from AJKD, which was published September 2024, because it's a beautiful table. It compares amyloid typing by IHC and IF on the left-hand side with proteomics with mass spectrometry on the right side. This has a number of advantages. One is that FFPE tissue, that is the paraffin tissue that we use for routine evaluation, can be used. And major advantage is a single test can be done, and it doesn't need any availability of antibodies which are specific for any type of amyloid. And of course, the most important thing is it's more sensitive and specific than either IHC or IF. But of course, the disadvantages have to be highlighted. It requires a specialized, experienced laboratory with very rigid quality control. And it requires, if you would notice the second point, adequate amyloid material. So small amounts of amyloid may be difficult to detect by this method. And what are the indications, therefore? If you do not have frozen tissue for IF, where you can't assess the light change, or you do not have IHC for the common amyloid types, then you would subject tissue to mass spectrometry for evaluation. So that is in short. I thought it was important to know this because some labs do it. Of course, it's not widely available as of now in India. So let's move on to what you can do with whatever armamentarium we have in our hands. The easiest thing to do is have frozen tissue and do an IF. If there's a light chain restriction, as shown in this picture, this is a glomerulus, and these are the mesangial deposits, which are intensely fluorescing with lambda light chain. But kappa was negative in this case, and therefore this indicates lambda restriction, which is equal to amyloid AL type. This is yet another case. I'll just show you a few cases, and that will make the understanding clearer. Look at this glomerulus. These glomeruli have this markedly widened mesangium with this pink material. Even the small vessel here actually has pale pink material. This is an HLE. This is a PA stain, very essential stain, because you need to see that this deposit is actually PAS negative. And you need to compare it with the intense staining of the PAS in the tubular basement membranes. This is the normal shade of a PAS positive material, dark pink to magenta. And this is actually pale, so it's negative. Look at this vessel. There's very pale pink material in the wall. So this is PAS negative material. And this is an IHC for AA, strongly lighting up. In IHC, brown stain is indicative of positivity. So you can see the glomeruli are all lighting up with this brown material, which is also seen in the vessel walls here, lighting up here in the vessel walls. This hilar vessel is also positive. So this was an AA amyloid. This is a simple test, and it can be done routinely in most laboratories. Now, this is just to show you that you can have the deposit of this acellular pale pink material in the interstitium as well. And this is essentially an interstitial deposit because these are the tubules, and this is the space between the tubules, which is nothing but the interstitium. So this is an interstitial deposit. This is a vascular deposit, which I just showed you in the earlier case. The vessel walls have this pale pink material. So various compartments can be involved, as I had mentioned in the first couple of slides. This is yet another interesting case, which shows you again the pale pink material. They are all very similar. Look at this blood vessel. This has this pale pink material. This glomerulus also has a pale pink PAS negative material. This is a PAS stain because this is the intense PAS positivity seen in the Bowman's capsule and in the tubular basement membranes, but you don't find that in this material, which has been deposited within the glomerulus. But on the IF, this was a beautiful case which has been graciously shared by one of my consultants, one of my junior consultants. The immunoglobulins IgG was strong positive. This is IgG, which is a gamma heavy chain. This is lambda, which is a lambda light chain, again, intensely positive. And kappa, you would see here, is negative. There is no staining, which means it is staining for one heavy chain and one light chain. And therefore, this is consistent with amyloid AHL, heavy and light chain type of amyloidosis. So that brings us to the most important thing. What are the differential diagnoses? Because a number of conditions can lead to these pale pink or eosinophilic deposits in the glomerulus. So how do we approach it? That is what I'm going to cover in the next few slides. So essentially, the two main groups that come into the differential diagnosis are diseases with monoclonal immunoglobulin deposits for obvious reasons, because if you have light chain restriction, then are you dealing with an AL would be the question. And then there are the other group of diseases with organized deposits, which can also, these 7-8 entities, which can have pink material or eosinophilic material in the glomeruli vessels and in the tubules or in the interstitium. And therefore, these form the main groups of differential diagnosis. However, if you look at the monoclonal deposit diseases, the most important differential is MIDD, or monoclonal immunoglobulin deposit disease, because that is the one which closely simulates amyloid. The others which are listed here have different features. For instance, PGN-MID, which is proliferative glomerulonephritis with monoclonal immunoglobulin deposition, that would actually look like a proliferative glomerulonephritis. So there will be a lot of cellularity, increase in cellularity. There could be crescents, there could be an MPGN pattern. So that would look very different from an amyloid. So similarly, a type 1 cryoglobulinemia will have pseudothrombi, and there will be material clogging the glomerular lumina. Light chain cast nephropathy would be seen in the tubules with light chain cast. So these have different features. What actually comes into the differential diagnosis is MIDD, and we'll look at a few cases in the next few slides. So are there some clues and are there some ancillary tests which would help make our life easier while diagnosing amyloid? Thankfully, we have ISC for some conditions. Fibrillary glomerulonephritis can look very similar to amyloid, but it has immunoglobulins and complements on IF stain. So if you have an IF to complement your LM study, that helps. And of course, now we have IHC with DNA JB9, which stains for fibrillary deposits. And the important point to remember here is that fibrillary can sometimes be congophilic. So that is where the confusion comes up. And also, they have some similarity in the EM, the size of fibrils on EM. So this is a very difficult diagnosis to make with confidence. But if you have these ancillary tests, then you should be able to make the diagnosis more confidently. Diabetic nodular glomulosclerosis, or the KW lesions, which we are so fond of, look very similar to amyloid, but they're strong PAS positive. So that helps make the diagnosis, of course, given the right history. So we need your help from the nephrologist in that we need to know whether the patient is diabetic. Otherwise, it can be very difficult. Idiopathic nodular glomerular sclerosis, very close differential for diabetic nodular glomerular sclerosis, but usually again past positive, but the patient would be non-diabetic and there would be a history of smoking. So these things, if elicited and written on the form, would make things a lot easier. Light and heavy chain deposition disease, again, would have IF deposits of light and heavy chains, and they can look like nodules, can be difficult to differentiate from amyloid. Usually amyloid doesn't form big nodules. So that is one soft pointer on the light microscopy, which can help you. Other diseases like collagenofibrotic, immunotactoid, again, can look very similar, but EM is what you have to resort to make the diagnosis. Hyalinosis, a very common condition. In most kidney biopsies, be it due to hypertension, due to aging, due to diabetes, you would find hyalinosis, and that can be confounding, especially to somebody who has just begun looking at kidney biopsies, but they're intensely past positive. So that is the way to make a difference. This is a table just enumerating the same changes amongst the common differential diagnosis of amyloid. The first column has amyloid. On light microscopy, you would have fluffy mesangial deposits, which are usually past negative to weak past positive, non-argyrophilic, so the silver stain will be negative. And if you have an AL type of amyloid, you could have lambda light chains or even kappa light chains with light chain restriction. C3c is usually absent, and on EM, you have 8 to 10 nanometer fibrils, which are randomly oriented. In light and heavy chain disease, a very close mimic, especially light chain disease, to amyloid, then they usually form nodules. There's nodular sclerosis. It's not a diffuse widening of the mesangium. So that is a clue often. And most importantly, they pass positive, silver positive. And depending on the type of light or heavy chain, which is responsible, they could have that on IF. Immunoglobulins, C3c would be positive, and they have dense granules on EM. They don't have fibrils. Unlike amyloid, they do not have fibrils. They have dense, electron-dense granules. This group of fibrillary, immunotactoid, and cryoglobulin also can be a close mimic, but when you need to look at the basement membrane. Both diabetes and these deposit diseases have a subtle thickening of the basement membrane. So if you're able to sort of look at that carefully, along with the other stains, you should be able to make a diagnosis. And of course, EM is confirmatory because fibrillary, however, has a close overlap with the size of amyloid. And it varies from 12 to 15 to 30 nanometers. So at the lower end of the range, it can be difficult. Especially, I remind again, though typically not congophilic, sometimes you could have congophilia in fibrillary glomerulopathy. However, immunotactoid has very large tubules, 20 to 30 nanometers, and you could have dense deposits in cryoglobulinemia, the type 1 type. Diabetes, of course, would be past positive, like I mentioned, and there will be no immune deposits. Sometimes, of course, one has to remember that you can get some smooth linear deposits of IgG in a diabetes, but the history, therefore, is very, very important. And in non-amyloid, non-immunoglobulin type of deposit diseases, like fibronectin and collagen, can be a little difficult, but often you get a thickened basement membrane. So if you get a thick basement membrane, these are three entities that one needs to remember and then match it with the rest of the findings. So I'll quickly show you a few cases which will make understanding easier of the differential diagnosis. Now, this was a typical case of diabetes. These are nodular lesions, KW lesions that we are so fond of, nicely past positive. You can see this hilar vessel also showing hyalinosis with past positivity. These are silver is positive here. This should have been negative in amyloid. And this is a Mason trichrome, which highlights these nodules. This is a case of amyloid. To contrast with that, the PS is negative, as you can see. There is no argyrophilia. So this is a silver stain. You can make out the dark stain of the Bowman's capsule and the tubular basement membranes staining black, but the deposit itself is negative. And this is congruent positivity for you. Hyalinosis, as I mentioned earlier, you can see at the red arrow, these homogeneous, very waxy, smooth deposits of hyaline can sometimes be confused for amyloid because they look very smooth, very similar, homogeneous, but they would be intensely past positive as seen on the picture on the right-hand side at the blue arrow. So those were the common differential diagnosis and the light microscopic pictures of those. Now, one point to remember is that in amyloid, you could have a combination of two diseases, as in most other pathologies. Though rare, you need to be aware. And this is one of our recent cases again, who was a diabetic and had these nodular glomerular sclerosis on HND. And on the PS, you can see that these are fairly intensely positive. There is a capsular drop here. But apart from it, there is this deposit of this pale pink material on the PAS stain in the interstitium. This pale pink material is an interstitial deposit of amyloid, which was actually congophilic. I don't seem to have that picture with me. So this is probably a combination of diabetic sclerosis with amyloid. And since the deposit was predominantly in the interstitium, we think that this could be an ALK2 associated with diabetic nephropathy. We, of course, haven't had the chance to confirm this because we don't have an IHC for this as of now. Okay, this is yet another case. All of you would agree. All these glomeruli are markedly expanded. This is the H&E stain. And the PAS shows this PAS negative material. The PAS positivity is here seen very clearly in this picture. The Barman's capsule, and this is actually periglomerular fibrosis, which is staining intense pink, but the deposit is negative. Just a closer look again. Here it is forming some sort of nodules. And actually, if you look at this, the basement membrane is very thickened. I just showed you on the table that this basement membrane thickening is something that one needs to be aware of and alerted. You're seeing this marked thickening of the basement membranes. So, and of course, when you look at the silver stain, this is not argyrophilic, and you compare it with the Barman's capsule, which is dark black. So this was PAS negative deposit disease. The differential first thing, we are talking of amyloid, so amyloid is certainly a distinct possibility. But the other thing to remember is that collagenofibrotic can look like this. Though books talk of silver positive deposits, we have actually had in many of our cases, 4 to 5 cases that I remember, which have been silver negative like this case. And this was subsequently confirmed with EM. So, and none of these chemical stains are hard and fast. So you have to remember that you can have things which look a little different from what the books describe, but one needs to be alerted. And you can see a very thick basement membrane everywhere. So when there's a very thick basement membrane, that's when you are alerted to the fact that all these are very thick and markedly thickened basement membranes, apart from the deposit in the mesangium. All this is the deposit in the mesangium. So you have to think of deposit disease in that scenario. Of course, if you have a congruent which is strong positive, that distinguishes it from a congruent negative collagenofibrotic or any other deposit disease, and EM is confirmatory. The picture on the left is amyloid with these thin 8 to 12 nanometer fibrils, which are randomly oriented against these large tubule-like structures or large fibrils, which are 25 to 30 nanometers in a collagenofibrotic. Yet another case I bring for you, and this is a PAS stain showing PAS negative deposits in the mesangium, not particularly silver positive. So you would be tempted to call it an amyloid. And here is a congorate. You can see some congophilia there. So most of these glomeruli are congophilic. And to our surprise, I mean, when we were thinking that this could be an amyloid, the IF showed immunoglobulins. There were no complements, but IgG was about 2+. So that was an alert. And we actually ran the DNA JB9 IHC. And look at this beautiful positivity. Any brown is positivity in an IHC, and therefore DNA JB9 was positive. And this, therefore, is a fibrillary glomerulopathy. Just again, a warning that these can sometimes be congophilic. Yet another case, again shared by one of our earlier students, because this is so rare, I don't think I would see one more, but I got this just for your benefit. And look at this again, the same sort of pattern in the H&E. PAS is sort of iffy, not particularly strong. If you consider this a strong positive, then this, the vessels and the basement membrane, then this looks negative. No argyrophilia. So again, one is tempted to call it an amyloid, but one must carefully look at all stains that one has. And this is a Mason trichrome, which shows strikingly functionophilic deposits. And that is a giveaway to the diagnosis. The IF in the case showed no immunoglobulins, but C3C was a coarse granular deposit, pretty significant, 2 to 3+. And we sent this for a fibronectin IHC, and Dr. Walker's lab actually did it. Akana's lab did it for us, and it was fibronectin positive. So a lot of these deposit diseases can look similar. And one has to remember that histochemical stains like PAS, silver, and Mason often depend on the mood of a technician that day. So silver is a tricky stain. Not every technician can do it well. So you can't go by it entirely, and you need the entire range of tests to check. And if all fails, EM should be done in these cases for a confirmation. So just a quick and simple algorithm for these conditions. If you have a deposit in the glomerulus or in the kidney, do a congorate stain. If the congorate is positive, it's likely amyloid. And depending on the IF findings of light chain, heavy chain, or combination, it could be any of these, either an AL or an AH or an AHL amyloid. If there is no light chain restriction or heavy chain deposition, then you could run an IHC for AA like I showed you. If that is positive, it becomes an AA amyloid. If the congruent is negative, then it's a non-amyloid deposit. Look at the immunoglobulins. Immunoglobulins, if they are positive, it could be either fibrillary, immunotactoid, cryoglobulin, or a light or heavy chain deposit disease. If immunoglobulins are negative, but you have the deposits which are not congruent positive, it could be either of these three conditions, either a collagenofibrotic, a fibronectin, or it could even be a sclerosed chronic sclerosis or sclerosed glomerulosclerosis. It's a very simplified approach. Just put in another table to further emphasize that if, of course, the congruent is positive, you're likely dealing with an amyloid. If it's negative, it's a non-amyloid. If the deposits are in the tubulointerstitium, you need to consider light chain cast nephropathy, crystal storing histiocytosis, and a host of other diseases. But if you do EM, finally, the confirmation comes from EM. So if you do an EM, and EM shows deposits which are powdery and dense granular in the glomeruli, TBM, and arteries, you could be dealing with an MIDD. Of course, there will be a light chain or heavy chain deposition as well on IF. Fibrillary is a distinct possibility if you have fibrils which are 15 to 30 nanometers. So they're a little bigger or almost double the size of amyloid. Then it's a fibrillary, and DNA JB9 would be positive. Immunotactoid would have tubules, microtubules, 30 to 50 nanometers. And these and PG and MID would have no organized deposits, but could have some electron dense deposits. Cryoglobulin, again, has microtubules. So it's important to remember that when in difficulty, when it's not matching everything that you have done, the routine stains and the IHCs, EM needs to be done to confirm the diagnosis and is mandatory. This is again taken from the AJKT publication of last year. It's a simple algorithm to type renal amyloid. So if there is amyloid, you suspect amyloid, look at the IF. If there's a light chain restriction, you're dealing with AL. If there is no light chain restriction, do an AA-IHC. If it's positive, it's AA amyloid. If it's negative, however, you need to resort to mass spectrometry. If AA is negative and you have access to LEG2, that is leukocyte, LEG2, the other amyloid, which is commonest, leukocyte, I forget the name, leukocyte chemotaxis associated. LEG2 is the A-LEG2 is this has an antibody for IHC now. So if it's positive, it's an A-LEG2, but if it's negative, again, you need to resort to mass spectrometry. So mass spectrometry is the one which will give you answers in majority of cases of amyloid. And of course, if you have access to EM, that would confirm the various types of amyloid. So this is just the last slide, and I'm sure you're bored of listening to amyloid. Just to alert all of you that I'm sure you know as well that the International Society of Amyloidosis meets every 2 years to update knowledge on amyloidosis. And the last publication, which was in 2024, amyloid in the journal is called Amyloid. They have now described 42 types of amyloid fibril proteins. I started off with 36 on my first slide. That is what literature had, the books had. But now this article says that 42 have been identified and 19 of which are associated with systemic deposition. They also mention that this iatrogenic amyloid deposits at injection sites are now known to have systemic deposition as well. So that these are the 2 points that this article makes, and I thought that was of relevance to this topic, so I put it here. And with that, I come to the end. Thank you very much for your patient hearing.
Thank you, ma'am. I'll just start with my thing. So a lot of things have been already covered by you. So I'll not waste a lot of time in the repeating things. But while I was just reading literature, I came across this this is given in the textbook of nephrology, the Shreyas, where it says Raymond classified amyloidosis into 4, that is primary, secondary, tumor forming, and myeloma associated amyloidosis. We no longer use it, but more or less this just gives a very vague idea that this is the thing that we are looking at, especially to correlate the illness and the biopsy findings. So in order to, again, have a better discussion, we have two nephrologists. We have our esteemed panelist, Professor Emeritus Dr. Sudhir Kulkarni sir from MGM Medical College, Aurangabad, and Dr. Suhas Mondhe, who is a consultant nephrologist and transplant physician from Pune. I welcome both of you.
Thanks.
Sudhir sir, Suhas sir, are you there?
Yes. Sorry.
Thank you, Purva, for giving an
Yes.
opportunity to be with the great personalities. Madam, you are a very excellent presentation. I have one question for you.
Yes.
Whether the normal light chains will be Congo positive, Congo stain positive, or it is structural change which makes them positive?
No. The structure changes. Only if it is amyloid, it will be congruent positive.
Okay. Otherwise, light chains
No.
will not be positive.
No. In fact, all our immune complex mediated glomerulonephritis have polyclonal light chains, but they're not congruent positive. It is that change in the structure which makes it congophilic.
Okay. Purva, shall I go ahead? You will ask the questions.
Yes. Sir, I will ask the questions to you and Suhas sir, and we look forward to your answers for this.
I have a question for madam, but I'll ask later.
Okay.
Yeah. So, ma'am has already made this elaborate discussion on the classification that there are 36 types, and now there are 42. This was back in 2020 with the International Society of Amyloidosis. And this is the picture where amyloid is in the mesangium. But ma'am has also explained the importance of mass spectrometry, which I'd like to know if it is available in India. But before that, just one highlight is that now there's a classification for renal amyloidosis also, which is into iatrogenic, mutant, acquired, and unknown. Ma'am has already given the details, but more or less is just categorization of the individual, the subsets into these four major headings. I'll not go into the details of mass spectrometry, which ma'am has already explained quite lucidly in her talk. But ma'am, while I was listening to your presentation, this thought came up. Is proteomics and mass spectrometry available in India?
Not yet, I think. That is the major problem, that it's not available, certainly for diagnostic usage. I think in the research setting, one or two places have it, but yeah, it is not routinely available for diagnostics. We know that, I mean, one or two cases we did send across to Akognos lab some years ago because there was a dispute and there was some, I mean, the case went to court, and then so we sent it to Akognos lab in the US. But yeah, I don't know of any lab doing it as of now in India.
Right. I mean, if a clinician wants to biopsy sample.
Yeah, so it's just a routine. That's why that same article, Dr. Purva said how to do it. So basically on the same paraffin sections that we use for light microscopic evaluation, congruent is done. And the congruent positive material by a method of laser microdissection is taken out, scooped out from the slides. And that is then further treated. I didn't go into those technical details, which I also don't know, but I have read of it. And that is subject to mass spectrometry. So that is from the routine biopsy material, not additional, no other tissue, unlike EM.
Right.
Madam, even
Yes.
though when we say that it's not available in India, or not routinely done it, or even on the diagnostic purpose, it's not available.
Right.
Apart from Arkansas, not many labs also don't use it very often. Means,
Correct.
even when I was in Canada for 4 years, none of the nephropathologists were like having access to the mass spectroscopy also
Correct.
that easily, which we feel that we are losing. So
Yes.
that is something like it should not be a like limitation on our part, right?
Correct.
Because
so the reason for the limitation also, Dr. Suhas, is that it needs very highly specialized technicians, technology, and it needs a significant amount of amyloid to be able to pick up. So it's not an easy technique. basically it's not something that can be done very easily, unlike what we do, like we do the light microscopy, we do IF. It's not a technology which can be just easily implemented. So that is the reason for its non-availability as of now. But I do hope, like most things, like how NGS is today affordable. When it started, it wasn't affordable, right? And we have come a long way. So I do hope that this will come to be, and soon it will be available like a routine test. I'm also waiting for that. I think that will make our life a lot easier, because all said and done, like I mentioned, all these stains that we do are finally a lot. It more than 75% depends on the technician doing it. So it has to be done very well. You have to have a significant load so that the technician out of practice does it routinely very well. So that's why I said sometimes the technician is in a bad mood. She's fought with her spouse at home. Your stains may not come out well. So it is a lot of, there are a lot of these factors which I think mass spectrometry will actually take away. And that will not be affected by these factors. So yeah, I think that's something to look forward to as far as amyloid diagnosis is concerned. But thankfully, majority are still AL, AL and AA, which we can pick up by our routine stains. At least 90% get picked up.
So,
And for as I mentioned that I'll ask a question, Purva ma'am, just for a minute.
yeah, sure.
So
Please go ahead.
sometimes we are not sure what the happening with the patient's progression of the CKD, and we get a biopsy. Biopsy shows that there is a lambda restriction 1+ and kappa 0. It's not that we are like hoping to find over there something like young guy, not much of proteinuria, creatinine just like in last couple of weeks increased. At what time we should be saying that it's like a significant one?
Sorry, I lost out the last.
So at what restriction we should say that there is a
right. So like so what your question is that when you see a 1+, should you call it restricted or not? Right? It's a young patient. You don't expect an amyloid.
Yeah.
So 1+ is not to be considered. And all IF 2+ and above are considered significant. So anything less than a 2+ is really not considered significant. So that could be a non-specific entrapment. Sclerosed glomeruli, a CKD, will just have some entrapment which may not be significant. So one has to be careful in those situations. 2+ and above is considered significant for all IF deposits. And the same rule applies for light chains as well.
Thank you.
Did that answer your question?
Yes, thank you.
So we'll move ahead with the next panelist. We have Dr. Sudhir sir. So we have a lot of questions for you, but we'll begin with the first one. In your experience, sir has a vast experience, almost around 40 years. What type of renal amyloidosis have you encountered, and which ones have been the most aggressive ones progressing to end-stage renal disease? Hello, Sudhir sir?
Sir, mute, sir. Please unmute, sir.
Acha. Sudhir sir? Hello, sir, we need to unmute. Yes, sir.
Okay. So amyloid itself is, although discussed widely, is a rare disease. It's not very common. So recently in a World Congress, we had one presentation from AIMS when they have a biopsy of 3,853 biopsies. And the incidence of amyloidosis is only 1.6%. So overall, the incidence of amyloidosis is not very common. What I have seen, we have almost 200 biopsies, and we had 8 patients of amyloidosis, of which 4 were AA and 4 were AL. Similarly, there are a lot of registries, Indian registries, by Dr. Rakesh Sharma, who has given AA amyloidosis 2% and AL amyloidosis 6% out of all biopsies. So overall, the incidence of amyloidosis is not very common, although we think it should be. So both are common. AA is common, AL is common. So there is no preponderance of one or the other. Okay.
Yes, sir. Sir, either one progressing to end stage renal disease very rapidly in a short period of time?
AL is more aggressive, although it is less common. A is more common in India. AL is less common, but it is more aggressive because of underlying etiology. The
Yes.
cells proliferate, and unless they are treated properly, we cannot control amyloidosis. So it's more aggressive. So out of all AL patients, 70% progress to kidney disease, and out of them, 10 to 20% can reach end-stage renal disease, which need renal replacement therapy.
Right.
So AL is more, AA probably inflammatory condition can be controlled. We treat tuberculosis, we control rheumatoid arthritis. So if the inflammatory conditions are treated, the disease can be controlled. Even post-transplant recurrence is less because these are treatable conditions.
Right. So, sir, in just to delve into the clinical features and the diagnostic aspect, we usually screen, of course, if anybody has albuminuria, especially with normal size kidneys and adult onset nephrotic syndrome, and other constellation of signs and symptoms, then we go ahead for kidney biopsy. But then a lot of times, while residency, especially during residency, when such cases were first referred from medicine, they used to go ahead for abdominal fat biopsy. And whether I want to have Meenakshi ma'am also on this question, is if does this, like, if the abdominal fat biopsy shows amyloid, does that mean that it invariably is there in other organs as well, or specifically only when the proteinuria develops is the time when you actually get a kidney biopsy?
Yeah, actually, there's a lot talked about abdominal fat pad biopsy and rectal biopsies for amyloid, but I'm yet to see an abdominal fat pad which shows a lot of amyloid. It's sort of, that's that mismatch between what is reported in literature and from what we get, or possibly in Western countries it is more, I'm not too sure, but whatever we have got, we don't seem to really be able to demonstrate. And yes, we don't usually get a kidney biopsy if the patient is not symptomatic. No, it's only when they're proteinuric or you're suspecting it clinically that we actually get a kidney biopsy. That's how it is in the practical scenario.
Right. Okay.
You can do rectal biopsy as well as gum biopsy.
Correct.
But usually the literature says the outcome is poor unless you have a lot of amyloid. You do not get a
you
positive.
won't get, you won't pick it up. So that's what, I think that way, if the kidney, if you're having proteinuria and the patient's symptomatic, definitely kidney biopsy picks it up much better, and we demonstrate it much better, so much easier. And you can do the entire gamut of IF, you can do IHC, all that. So abdominal fat biopsy, they even do aspirations, like an FNA. But like I said, I am yet to see a case which came positive on an aspirate of an abdominal fat. So that's been our experience, though.
And sir, those who have kidney, like those who have amyloid, I just had I probably seen just one case where we got scintigraphy done. And we were just told that as per textbook, you will get that speckled pattern. But we didn't see it in that patient. But do you think these patients who have such findings, of course, doing a non-invasive test for the heart is much better than doing anything invasive. Does this have any repercussions, or does this have any adverse outcome in such particular patients?
Involvement of, you mean involvement of heart?
Discussion. Yes, yes.
Involvement of heart it speaks of poor prognosis. The patients who have heart involvement, they do worse even after transplant. The prognosis is not good. So those patients have only kidney involvement. The progress is good. The response to treatment is good. Well, the heart involvement speaks of poor prognosis even after transplantation.
Yes.
And instead of scintigraphy, you can do just MRI, which shows bright images
Pattern.
and thickness of interventricular septum. So MRI is an easy method than scintigraphy.
Right. Yes. Yes, sir. So moving ahead, this is from the literature. What I was understanding while how we treat amyloid is, irrespective if the patient is at low risk for receiving a bone marrow transplant, intermediate risk, or high risk, all of these categories, they receive this cybordics regimen plus daratumumab, or they receive a bortezomib based induction therapy. So eventually, if all amyloids, are they supposed to be treated the same or differently, we'll know in the next questions. But I wanted to highlight for the fact that in this review, what they have shown is, irrespective of the category of the risk of the patient, they are supposed to receive one of these two regimens. The low risk patients are considered for the bortezomib induction therapy, while the intermediate and high risk patients, they can undergo Cybody regimen, that is cyclophosphamide, bortezomib, and dexamethasone plus daratumumab regimen wherever accessible. Now, sir, Sudhir sir, to you, this question is to you. As per your experience in treating amyloidosis, how do patients do when receiving Cybody regimen?
Frankly, we don't treat amyloidosis, we send it to hematologists. So personally, I never treat patients of multiple myeloma or amyloidosis. But the literature, what this Andromed trials says, the response rate is 53%. So the response to chemotherapy is not very good. So complete remission is seen in only 50%. Then there are some only partial remission and some are resistant. So those who do complete remission, they are good candidates for kidney transplantations. So personally, I don't have experience of treating amyloidosis or even multiple myeloma. We usually refer to hematologist.
Okay. I have seen one. He was started on the bortezomib based regimen. He received 5 injections. But after that, we didn't know what to do. I mean, as the nephrology department, as rightly sir said, that we have to involve the hematologist, and probably, when they are in remission or when they are doing fairly well, they might just preemptively consider a bone marrow transplant to prevent recurrence. So
Daratumumab actually is a little bit costly treatment, even though hematologists are preferring it nowadays. It's a considerably cost. Means patients most of the times refuse the treatment and are happy to be continued with just bortezomib based regimen, just because that they feel that daratumumab is not affordable most of the times. So
right. Is it available?
hopefully when the prices get,
It's available.
It's available.
It's available. The cost of one dose is 56,000.
Yeah.
Oh, okay. So, yeah, moving on. My next question is to Suhas sir. Just continuing the previous discussion.
I will
Now
just
that we
mention
have,
1 minute. I will just interrupt. In case
sorry,
patient have cardiac amyloidosis along with renal.
no, sir, no, sir.
No, in case patient have a cardiac amyloidosis with renal
Sorry.
amyloidosis, we have to be careful because the usual drugs which are used in treatment of congestive heart failure, they are all contraindicated with amyloidosis, like beta blockers, digoxin, calcium channel blockers, and diuretics because of postural hypotension. So you have to be aware that whether patient has cardiac disease, you may treat edema with diuretics, and patient may have postural hypotension. The conduction defects are more common. So drug of choice or the
Arrhythmias are
patient
more
may be
common.
put on
So
amiodarone and pacemaker because they don't have bradycardia. So if the patient has a cardiac disease along with renal disease, we have to be very careful.
Right. So I think, sir, in that scenario, if the patient had a cardiac amyloidosis, they would not be a good candidate for transplantation also, right?
Correct.
it will be very
They will
difficult to
need
get a
both.
cardiology clearance for the transplant also.
They will need heart plus kidney transplant.
Correct.
Because the moment you send this patient to the cardiologist to get a permission, the cardiologist will explain about the arrhythmias, recurrent heart failures, and it's non-ischemic, right? So the patient may not be like a good candidate for even like um, ongoing cardiac recurrent hospitalizations, and also to get such patients on dialysis also is not the best choice. So I know transplant should be the treating factor over here, and literature describes it a lot. But to counsel such patient for transplant of any kind is like one bigger challenge to face.
Safer will be peritoneal dialysis. So probably hypotension and
Yeah,
postural
but
trough.
still, so dialysis also these patients don't do that good. I have seen some of the patients, I have seen at least 2 patients who are doing good on peritoneal dialysis. So not
Correct.
hemo was my choice, but I
Correct.
suggested them that for more than hemo, prefer to get on the peritoneal, but
Peritoneal dialysis.
it was like that difficult choice to explain.
Right.
So for monitoring these patients, I will definitely take care of the like creatinine, urea, like all the our like panel of the kidney disease, and I do it every monthly. So it's just that these patients are more prone for AKS, so I ask them to get this done every monthly. They may or may not see nephrologist every month depending on the need, but yes, to see the progression of the disease, to understand whether the patients are going into the remission, because sometimes even though patients are achieve remission, they still can go into the relapse later. So it's better that if they are ongoing treatment, to get things managed regularly. Protein creat ratio, if there is some doubt, I still get 24-hour urinary protein and light chain assays. So light chain assays I still get once a month. So uh, even patients who are off treatment, light chain assay sometimes helps them to predict the um, early relapse. So one of my patient who received almost like 70 chemos was off treatment for 2 years, and the first thing to go was the light chain assay. So probably that is something that we should keep in mind, that protein creat ratio, light chain assays, protein urea, and renal functions. These are probably the renal parameters. Apart from that, I would definitely consider getting their echos every 3 months just to understand that if they are getting a cardiac involvement or not also. So they get peripheral neuropathies and other sides like complications also, right? So it's better to monitor them, and that will guide us to counsel the patients also. See, now you got renal involvement, cardiac involvement. So we need to be like more cautious and take care precautions regarding the further hospitalizations and like how we can manage the progression and achieve remission.
Right. By any chance, does treatment allow reversal of these lesions on biopsy? I mean, it's just out of this discussion, what we are having, a thought. Like for example, when we have membranous, there is remodeling of the glomerular basement membrane. Something like that, like are we looking at the other side disappearing?
I have never been that lucky to have like good remission of my patients. So out of three, two progressed and reached ESRD. One of them is the one who, like after 70 chemo, again had a relapse. Now the hematologist is suggesting to have a daratumumab, and he's refusing just because of the cost reason. So that's why, for me, he's the one who is the only success till now. So whether it reverses, probably I haven't seen. The creatinine is stable at around 2.4. So fingers crossed.
Right.
But ma'am can answer this question. So
Yeah, so I can't really answer, but it's just that you need a follow-up serial biopsies to know whether it reversed. Otherwise, it's impossible to say, answer your question.
Yeah, but an amyloid disappearing would be something very, I mean,
Difficult because it
yeah.
doesn't get degraded. So I imagine that it won't be that, that conformational change gives it the stability and it doesn't get degraded easily. So
Yeah.
that is, I don't think it would disappear, but yes, I do not have an experience where we followed up a patient with serial biopsies and seen how he or she has done. So that would be the only way to establish. But I had a question for Dr. Suhas. How often would you do the free light chains? You said that you follow up with free light chains.
So I did every 3 monthly for that patient.
Okay.
Just I wanted to understand whether he's still responding to the treatment or not.
Correct.
And luckily, he achieved normal levels of chain assays. So I was like happy, the family was happy. And he maintained that for almost like 12 months. And then again, he had a relapse. So yeah, that was a challenge.
Are you giving any maintenance therapy, like any, like
MABs or
any?
MIBs?
Sorry, a maintenance therapy of?
like any specific drug in which where after
No,
the
he just had
patient.
a stable CKD, right? So I was treating you with the ARBs and dapagliflozin. So that was the only I chose to continue. I thought that I even told the patient that now looks like your disease is under control. So hopefully it will not come back, but devil's mouth. So
In such case, melphalan is used. In case patient relapses,
Yes.
then we can use melphalan, which was the old drug first tried in amyloidosis. Another thing, Purva, there must be some PG students for managing AA. There are certain drugs which are, one is anti-TNF agent, that is etanercept. Then IL-6 receptor antagonist, tocilizumab. And for IL-1 blocker, anakinra and rilonacept. So for PU students, at least for writing a question, so AA amyloidosis also is treatment. It is not only AL we can treat, even AA we can treat. So these are the new agents tried.
Yes.
Madam mentioned regarding the serial biopsies, sir, but in the unit where I got trained, there was a dictum if the patient did look for amyloid first. The patient might be having amyloid underlying. So or rather, we never had a courage to put the needle again just to see that whether the patient has responded or not.
I'm
So
just academically
I'm not sure whether it's a true or not. It was just a dictum in the unit. So there was a hesitancy to put a needle again into the kidney.
Of course. No,
Okay, Meenakshi बोलू. हाँ. Yes. तुम्हीच खुणवा त्यांना. वळा पूर्ण तुम्ही.
Okay. Yeah. So yeah, the next question is we will be wrapping up soon, but before that, Suhas sir, would you like to do an MG work up all amyloid patients for MGRS or myeloma in the spectrum?
Yes, I would, because so it's for two things. First of all, as I mentioned, that if at all something comes positive, it's like a one thing to be treated for. And the second, it will be easier for me to talk to my patients about the prognosis, because that's something the patient wants to know more than anything. They don't want to know about the follow-up of the treatment, how long the treatment will be. They are interested in asking two questions. First of all, whether this will get like completely stop, completely revert back, or whether this is going to go progress. And because unfortunately, the outcomes, as sir mentioned, like 53% only response, right? So most of them, they don't do good. And that's why prognosticating them early in the path of their treatment, something that I will look for. So probably I'll look for rule out all the MGRS.
Right. So in on this discussion, I also remembered one of our nephrology colleagues from Kerala, Dr. Jitu. He had presented about fibrillary and immunotractoid amyloidosis. Are you there, Dr. Jitu?
I think I saw him. He was there.
Okay. Probably we exceeded our time. Probably that is why. But I would what I also wanted his comments on the same. But before that, this is the slide I'd want everybody to focus on, is that what sir said, that should all amyloidosis be worked up for MGRS or myeloma spectrum. What they found out in 229 patients, and this is a very old study in Mayo Clinic, but what you can see here is that without myeloma, there were 182 cases. With myeloma, there's 47. But even when the number is less, for you are 47, that is out of 229, almost like 20%, somewhere between 15 to 20%. So it is essential that we do the workup, because that can assure everyone that they are on the right track and they may not progress to the extreme end of the spectrum. Now, coming to the last question to Suhas sir. As I mentioned, since ma'am has already discussed that fibrillary and immunotractoid are non-amyloid, come under the non-amyloid category. But this diagnosis is often disheartening, because does that mean that there is a dead end with no substantial therapies available, and it's just a merely a EM diagnosis on paper to be taken on paper.
There are some literature of using rituximab also, so I don't see that it's like a dead end. We can definitely decrease the progression with our routine pillars. But along with that, there are some case reports of success with the rituximab and monoclonal antibodies, immunosuppression. So probably it can at least retard the progression of the disease. So not a dead end for sure.
Right. So we've had one case, and I think ma'am must have seen many, and that since the invention of DNA JB9 coming positive for fibrillary, probably the college patients who are, maybe Sudhir sir also might have come across fibrillary immunotactoid. I had seen one during residency, but we didn't have any answer. All we did was give ACRBs for the patient for proteinuria.
Fortunately, they are rare. So I think
Rare.
so that's good.
Right.
So Purva madam, whether you will try immunosuppression for these patients?
What I have seen is not exactly like in the subcategories of amyloids where we have seen that they are not MGRS. Sorry, they are MGRS. Where there is light chain. What I have observed is after they achieve remission or the proteinuria has significantly come down, we have tried mycophenolate mofetil. And I remember we have two ladies, and one, she's doing very well. Like every 6 months, we do her free light chain assay. There have been times where she has swayed here and there 1 or 2 times, and we have just increased the dose from say 180 milligrams to probably 360 milligrams of mycophenolate sodium, and it has responded. Now, that is why I keep wondering that, what must be acting, because it's a block of protein, abnormal protein. And how can a drug, be protecting the protein mechanism and act as anti-proteinuric? What must be happening inside? We don't know.
Yeah, I agree.
So, coming to, as I said, Dr. Jitu had to leave because he texted me. So probably some other time we can have a discussion. He had presented an entire presentation on fibrillary and immunotactoid glomerulonephritis at one of the meetings like ISN. So it would have been great to have him. Now, the last question is to Sudhir sir. Sir, of course, now it is rare, but how should one manage the risk of amyloid deposition in transplanted kidneys in case a patient with amyloidosis has end-stage renal disease and now wants to undergo transplant?
First is the disease has to be controlled. The patients who have complete remission or even good remission, partial remission, they do better. But still the incidence of recurrence is 34%. Only French study has given very less recurrence, that is 5%. So first is well preparation of a patient, and about donor, you never should take a marginal donor, elderly donor, and a related donor. So that will also prevent the recurrence. About immunosuppression, too heavy immunosuppression is also not good. Otherwise, disease recurs. So keep optimum dose, never over immunosuppress. That is another thing. And treatment of if it is AA, the condition which has produced AA should be controlled. That means any infection, chronic inflammation, that should be controlled. So drug like colchicine may be tried, but the colchicine sometimes interfere with immunosuppression. You have to monitor the levels of immunosuppression. Tacrolimus is preferred to cyclosporine because of more interactions with cyclosporine. Otherwise, recurrence is common, and even the graft failure is also common.
Right. I think, sir, if probably prior to kidney transplant, they may consider autologous stem cell transplant also. That may prevent recurrence, if I'm not sure. Just
So first we have to do stem cell transplantation, and then we should do kidney transplant. Cannot be simultaneous.
Yes, sir. So with that, we come to the end of the panel discussion and our webinar today. I'd like to thank Meenakshi ma'am, Sudhir sir, Suhas sir for their active participation. Tomorrow is International Women's Day, and on March 13th is World Kidney Day. And this year's theme is "Are your kidneys okay?" And the best answer to that is a biopsy. So with that message, I'd like to encourage everyone that whenever possible, educate the physicians, educate primary healthcare professionals how important it is to biopsy kidney disease patients to actually assure them whether their kidneys are okay or not. So thank you all. Thank you for wonderful.
Thank you so much.
Thank
If
you
there's
very
any
much.
Thank you, ma'am.
comments
Doctor.
from your end, sir.
Nice discussion.
Thank you.
Probably
Thank you.
word kidney is a female. That's why there are more women in nephrology.
Is it female? Is it feminine? Okay. Thank you. Thank you very much, Dr. Purva. Thank you, Dr. Kulkarni. Thank you, Dr. Suhas. It was nice interacting with all of you. Thanks a lot.
Thank you.